Hi, and welcome to Radonc Talks, a lecture series designed for students and residents of radiation oncology. My name is Ria Mulherker. I'm currently a PGY4 resident at the University of Pittsburgh. And today, I'm going to be presenting some slides on how to understand radiation dose, fractionation, and how that applies to how we think about toxicity caused by radiation. This is a talk that I wish I had had, especially as a medical student, when I really didn't understand a lot of radiation biology. And my goal in this presentation is to kind of take some complex radiation biology concepts that we end up learning as part of our radiation biology curriculum during residency, and kind of breaking that down and simplifying it to make it applicable in a clinical context and to kind of explain how we think about radiation dose and fractionation and how that applies to toxicity in a very practical, clinical way. When it comes to understanding dose, fractionation, and toxicity, the very first thing to understand is that the effective radiation dose, or the radiation that actually has an effect on the tissue that we're treating, that dose depends on many factors. So total dose is one of them, but dose per fraction also matters a lot. So giving 50 gray in 25 fractions is a lot different than giving 50 gray in 5 fractions. If you compare 60 gray versus 50 gray at 2 gray per fraction, 60 gray is more than 50 gray. That's easy, right? We're comparing apples to apples. But if we compare 60 gray at 2 gray per fraction, that's 60 gray in 30 fractions, to 50 gray at 10 gray per fraction, so 50 gray in 5 fractions, now we're no longer comparing apples to apples. We're comparing apples to oranges. So the dose per fraction, if we're giving 50 gray in 5 fractions, is a lot higher. And so then the effective dose, something we also call the biologic equivalent dose, is higher for 50 gray in 5 versus 60 gray in 30 fractions. I hope that makes sense. So the point is that the dose that's perceived by the tissue, it doesn't just depend on the overall total dose that we're prescribing. The dose that we're giving with each fraction really, really matters. The third thing that's super important to consider is the sensitivity to fractionation of the tissues that are being treated. Another term for this is something called the alpha-beta ratio, which we will break down on a later slide. But for now, just consider this. Certain cells in our body that are rapidly dividing, like skin cells, the cells that line our GI tract, and also rapidly dividing tumors, they are rapidly dividing, and so they're very sensitive to radiation. So to those very sensitive, radiation-sensitive cells, it doesn't matter so much if we give radiation at a small dose per fraction or a higher dose per fraction. They're sensitive to radiation overall, but they are not as sensitive to the dose per fraction. On the other hand, cells in our body that are more slowly dividing, such as cells in the spinal cord that aren't really even dividing anymore, they are not so sensitive to those small doses per fraction, like 1.8 gray or 2 gray per fraction. But as we increase the dose per fraction, they get a lot more sensitive to fractionation. And so for those slower dividing cells, the dose per fraction matters a lot more. And so the sensitivity of the tissues that we're treating to that dose per fraction is also going to play a part into determining the biologic equivalent dose. So all of these things that we just mentioned, the total dose, the dose per fraction, and the sensitivity to fractionation of the tissues that we're treating, which is also called the alpha-beta ratio, they weigh into our effective radiation dose, or the biologic equivalent dose. The last thing that really matters is total treatment time. We have multiple studies in different disease sites, such as head and neck or gynecologic cancers, that tell us that the total treatment time matters. If you prolong radiation treatment or if you have long breaks during the course, outcomes are worse. And so the total treatment time that we deliver the radiation truly matters a lot. There are certain radiobiologic equations that try to factor in total treatment time, but I think time is probably one of the factors that's least well understood. We understand the dose per fraction, and the sensitivity to fractionation a little bit better, and so those are the things that are conveyed in the mathematical models that I'll present later in this talk. The total treatment time, it's important to realize that matters a lot too, but it's not as well understood as these other factors. Now, all of this is kind of extrapolating, right? We're extrapolating based on different experiments that have been done, different mathematical models, and these are all things that have been derived by people that are much smarter than I am. But I'm just trying to very simply convey my understanding of what plays into the effective radiation dose, or the biologic equivalent dose that we're actually giving to the tissues that we're treating. And to keep it very simple, a lot of things matter, but the total dose, the dose per fraction, the sensitivity to fractionation of the tissues being treated, and the total treatment time. So we mentioned this idea of the alpha-beta ratio. The alpha-beta ratio is a number that comes from the linear quadratic model that's used to describe cell kill from radiation. Alpha describes the linear component of cell killing, or in other words, cell kill that is due to a single hit. The beta value describes the quadratic component of cell killing, or in other words, the cell kill that is due to a double hit. The alpha-beta ratio, if you're asked to select an answer on a multiple choice test, the answer for what is the definition of alpha-beta ratio, the definition is it is the dose of radiation at which the linear component of cell killing equals the quadratic component of cell killing. So alpha-beta ratio is the dose of radiation where the linear component of killing equals the quadratic component of cell killing. Now that equation here on this slide is one that you might need to memorize down the road if you're ever going to take a radiobiology exam. But for now, what you should really understand is that alpha-beta ratio gives us a measure of the sensitivity of a particular group of cells to fractionation. So the higher the alpha-beta ratio, the less sensitive they are to the sparing effects of fractionation, which is another way of saying that the higher the alpha-beta ratio, the more sensitive they are to radiation at any dose. And so how much dose per fraction you give just doesn't matter as much, because any dose of radiation is probably going to have a similar effect. They have a higher component of alpha cell kill, so cell killing due to a single hit, and they're just more sensitive to radiation in general, but they're less sensitive to fractionation. It makes a lot more sense to look at this visually, probably. And so let's take a look at these cell survival curves using the linear quadratic model. Cell survival curves are plotting the survival fraction on a logarithmic scale against the dose. And when you're looking at survival curves for the linear quadratic model, it's important to realize that there are two portions of the curve. So the first portion of the curve is determined by the alpha component. Alpha, remember, is the linear component, or the cell killing that corresponds to a single hit. And so it's linear, and it determines that initial slope of the curve. The beta component, remember, is quadratic, and it's proportional to the dose squared. And so that quadratic component, or that beta component, curves down more sharply. It contributes to how quickly and how sharp that curvature is. And so whenever we're looking at the cell survival curve for two different tissues with two different alpha-beta ratios, we see that for a tissue with a higher alpha-beta ratio, so take alpha-beta ratio of 10, and that corresponds to curve A in this picture, the alpha component is going to predominate. So it's going to be more linear looking. And as you can see, the survival curve for the higher alpha-beta ratio tissue is straighter. It's a straighter survival curve. So when the alpha-beta ratio is higher, we say that these cells are less sensitive to the fractionation. And these tissues that have a high alpha beta ratio are also called early responding tissues. They're not as sensitive to the fractionation, but they're just sensitive to radiation overall, and they're early responding tissues. So an alpha beta 10, that alpha linear component predominates, so these curves look straighter as well. On the other hand, if we look at a curve for a tissue with a lower alpha beta ratio, this is an example with an alpha beta ratio of 4. In this case, the alpha is not as high, and so you can see that that initial slope in the shoulder region is less steep, but there's a lot more curvature because now the beta component is predominating, right, at this lower alpha beta ratio. And so the curve is much more prominent, and this corresponds to lower alpha beta ratios. These are the tissues that are less sensitive to radiation overall, but they are a lot more sensitive to that dose per fraction. And these are known as the late responding tissues, and they have a lower alpha beta ratio. So just take a look at these curves and kind of remember what they look like in your mind. And the key part that I want you to kind of focus on for the moment, just because we're going to talk about it in our very next slide. The part that I want you to focus on just now is kind of take a look at both of these curves and what happens to the surviving fraction as you increase the dose, right? Initially in the curve, they're both, sort of equally sensitive to the radiation. They're not exactly equally sensitive. You can see that curve A with the higher alpha beta ratio seems to be a little bit more sensitive to radiation. But they're kind of, along the same lines. However, as that dose increases, as we get above 10, above 12 gray, there becomes a much sharper difference between these two curves, between curve A and B. And you can see that lower alpha beta ratio, so that's curve B, is much more sensitive to the radiation at a higher dose per fraction. So if we were to hit this tissue with 15 gray, the tissue that's alpha beta ratio 4 would be much more affected than the tissue that's at alpha beta ratio of 10. Okay, so look at that, think about that, and also keep in mind what the shoulder of these two curves look like. And remember that shoulder refers to the initial area where we have that initial slope of the curve determined by the alpha component. So keep in mind what that shoulder looks like. So here we are at the next slide. And do you remember what those shoulders looked like on those two curves? Whenever we fractionate radiation, so let's say we want to give 50 gray. Instead of giving that 50 gray in just 5 fractions or in 20 fractions, by giving it in 25 fractions at 2 gray per fraction, what we're doing is reproducing that initial shoulder region of the curve. And we're kind of exploiting that difference between the high and the low alpha beta ratios of different tissues. And, with the understanding that tumor, which is rapidly dividing, as well as other early responding tissues that tend to be rapidly dividing, they are less sensitive to fractionation. So they are less likely to be protected by decreasing that dose per fraction. On the other hand, if we take the late responding tissues, so the cells with a lower alpha beta ratio that don't have as steep of a shoulder portion because that alpha component is lower, so that slope is a little bit milder and that shoulder looks a little bit flatter. If we take advantage of that and kind of keep reproducing just that shoulder region by giving 2 gray per fraction, we're kind of taking advantage of that, exploiting that fact to sort of protect these late responding tissues and, hit the tumor as well as these early responding tissues a little bit harder. So hopefully that made a little bit of sense. And just to kind of summarize what we have been alluding to this entire time, here is a table kind of comparing early responding tissues versus late responding tissues. Now, when we think about early responding tissues, we typically say they have an alpha beta ratio of around 10 gray. And late responding tissues, typically in radiation, we say have an alpha beta ratio of around 3. Now, keep in mind that any tissue is heterogeneous. So even if you're looking at, let's say, a head and neck cancer, and you're looking at all of the cells in that particular tumor, all of the cells in it may not have an exact alpha beta ratio of 10. There may be some variability within that tissue. But again, this is just an approximation, and it's really an extrapolation and an approximation that we're using. So I'm saying in general, we say early responding tissues have an alpha beta value of 10 and late responding tissues have an alpha beta value of 3. You will encounter different studies that actually go and calculate it, and there are slight variations, and they're in that range, but maybe not exactly at that value. But those are good numbers to kind of have in your mind. Alpha beta 10 for early responding tissues generally, and 3 for late responding tissues very generally. So what are the early responding tissues? As we said earlier, think about cells that are rapidly dividing. So most tumors tend to be early responding, especially tumors that are rapidly dividing, like head and neck cancers. Also, any cells in our body that are rapidly dividing, so skin cells, intestinal cells, bone marrow. Late responding tissues, think about cells that are either not really dividing or dividing much more slowly. So certain cancers, we've learned, actually behave a little bit more like normal tissue. So slow growing cancers like prostate cancer and sometimes even breast cancer, these have an alpha beta ratio that's closer to 3, which is actually closer to a lot of our normal tissues that are late responding tissues. Other normal tissues that have low alpha beta values, usually around 3, include the lung, the kidney, liver, bladder. The spinal cord, we sometimes think of it as more sensitive. And if you want to think of it as more sensitive to fractionation, some people will use an alpha beta value of around 2 gray for the spinal cord uniquely, just because it's so much more sensitive to fractionation. Now, one thing to keep in mind is that early versus late responding tissues should not be confused with acute versus late toxicity. Okay, so acute versus late toxicity is different, and all types of tissues can have both acute and late toxicities. Early responding tissues tend to have both acute and late toxicities. Late responding tissues, again, you can see both acute and late with both of them. But keep in mind that the early responding and the late responding tissues is something separate. And again, I just want to reiterate that these are highly oversimplified estimates. You will see different studies that have more specific estimates for alpha beta ratio, but it's good to kind of keep in mind, generally, we think of early responding tissues as having alpha beta of 10 and late as having an alpha beta ratio of around 3. Another graphical way of looking at these alpha beta ratios and how different tissues of different alpha beta ratios react to things is by looking at something called these ISO effect curves. So the ISO effect curves, on the x-axis plots the dose per fraction, and on the y-axis it plots the total dose at which you see various side effects. So the ISO effects, the same level of side effect. And so on this curve, the early responding tissues actually tend to have shallower ISO effect curves. So that means that as we compare the dose per fraction, they're not as sensitive to the dose per fraction. And regardless of what dose per fraction we're looking at on the x-axis, if we look on the y-axis, they're more likely to have a similar reaction, for that same level of total dose. If you look at the late responding tissues, however, like the spinal cord, the lung, the kidney, these tend to have a much steeper ISO effect curve, which corresponds to a higher sensitivity to fraction size. So if you look at that dose per fraction on the x-axis, as that varies, you can see that as we decrease the dose per fraction, so as we move towards the right on that x-axis, it takes a lot more dose of total dose in order to get that same ISO effect. And so essentially there's more variation as you move across that x-axis, which represents dose per fraction. And because there's more variation there, we know that that is how late responding tissues behave. And so these late responding tissues tend to have that steeper ISO effect curve. And so finally, now that we have spent tons of time kind of breaking down and understanding how the alpha-beta ratio works and what it means for tissues, we are ready to talk about the biological equivalent dose. Remember at the beginning we said that effective dose depends on many things, and 3 of those things are represented in the biological equivalent dose formula. So the BED is calculated by multiplying the number of fractions times the dose per fraction times this thing in the parentheses, which is 1 plus the dose per fraction divided by the alpha-beta ratio. Now, you don't need to memorize this formula unless you're getting ready to take the RadBio board exams, as I am this year. But what you should realize is that when we think about the biological equivalent dose, a lot of things are playing into that. We are thinking about the number of fractions, the dose per fraction, as well as the alpha-beta ratio. Those are 3 of the 4 things that we talked about on that very first slide, going over what plays into effective dose. The only component that we're missing here is time, okay? But the biological equivalent dose is very commonly used to kind of conceive conceptually how much effective dose we are giving to different tissues. And it's important to keep in mind that for the same dose of radiation, the biological equivalent dose to the spinal cord versus the head and neck cancer is very different, right? Because they have different alpha-beta ratios. So even if you're using the same dose per fraction and the same number of fractions for the same overall total dose, the biological equivalent dose to those tissues will be very different. So the biological equivalent dose, or the BED, is very useful for us when we are comparing the dose to a particular tissue when there's different dose per fraction regimens. So for example, in lung SBRT, some of the common dose fractionation schemes that we'll use are 50 gray in 5 fractions, 48 gray in 4 fractions, and 54 gray in 3 fractions. And these are all different because they're all different dose per fraction. So you can't really compare just the total dose because it's not apples to apples, as we talked about. And so a useful way to compare how much radiation we're actually giving when we're using different dose per fraction schemes is to convert everything to the biological equivalent dose and compare it for whatever alpha-beta ratio for whatever tissue you're looking at. Other than the BED, another useful way of converting different dose per fraction schemes and kind of making it so that you're comparing apples to apples is to look at the EQD2, or the equivalent dose at 2 gray per fraction. And again, these are equations that you don't necessarily need to memorize right now, but they are equations that kind of help us to understand what goes into calculating the EQD2. So there's 2 different equations that are here. And as you can see, they both take into account the total dose and the dose per fraction, as well as the alpha-beta ratio. So here is some proof that 50 gray in 25 fractions is different than 50 gray in 5 fractions. These are screenshots of EQD2 and BEDs taken from the website eqd2.com. Anyone can visit it and do these calculations for any dose per fraction and total dose combination. But I just decided to compare 50 gray in 25 fractions at 2 gray per fraction to 50 gray in 5 fractions at 10 gray per fraction. And as you can see that for 50 gray at 2 gray per fraction, the EQD2 is equivalent across all alpha-beta ratios, but the BED is different. The cells that are late responding tissues, so those alpha-beta 2s and the alpha-beta 3s, they are, the BED for those tissues is higher than the BED for a tissue at alpha-beta of 10. You can see as we increase the fraction size to 10 gray per fraction in the second column, that BED and that EQD2 jump up significantly for tissues that have an alpha beta of 2 or 3 compared to tissues that have an alpha beta of 10, right? At 10 gray per fraction and a total of 50 gray, the BED for a tumor at alpha beta 10 is 100 gray, but the BED for, say, your spinal cord, if you're using alpha beta of 2 to estimate the spinal cord radiosensitivity, the BED is 300, so 3 times that of the tumor. And so this is just kind of visual proof that those lower alpha beta tissues, those late responding tissues, they are more sensitive to fractionation. And as I was saying earlier, the EQD2 is also a great way of quickly converting in between different dose per fraction regimens. So if you're looking at 2 different radiation regimens and they are prescribing a different dose per fraction, you can quickly compare them to either EQD2 or BED to kind of compare those 2 different regimens and get a sense of how they compare. Convert them both to apples so then you can compare apples to apples. The other thing to remember is that all of these equations, as we just showed, take into account total dose, dose per fraction, and the alpha beta ratio. Remember, we said that time matters too, but these equations that calculate EQD2 and BED do not actually take time into account. So very briefly now, we talked about early responding versus late responding tissues, and we said these are not to be confused with acute versus late toxicity. I want to take a moment just to kind of talk about toxicity and how there are 2 different buckets in radiation. We say there's acute toxicity that happens during radiation treatment and in the first couple of weeks after radiation treatment as the body is acutely responding to that radiation. Acute toxicity is characterized by inflammation, and it's actually a function of the total dose that we're delivering. So if we deliver a total dose that's higher during that radiation period, then the acute toxicity, we expect it to be worse. If we deliver a total dose that's lower, then we expect that acute toxicity to be improved. Late toxicity, on the other hand, is characterized by fibrosis and sclerosis. As you can imagine, fibrosis is something that happens long-term in the wound healing process. Late toxicity is a function of dose per fraction. And so whenever patients are being re-irradiated, whenever they're going through a second course of radiation in the same site, you'll often see that we decrease the dose per fraction. So instead of giving even conventional fractionation of 1.8 to 2 gray per fraction, we will often decrease the dose per fraction to 1.5 gray per fraction. So for example, in breast cancer, there is a study, an RTOG study, that looked at re-irradiation of breast cancer patients, and they treated the partial breast to a dose of 45 gray in 1.5 gray per fraction, and they delivered the treatment twice daily. The reason we deliver a lower dose per fraction in the context of re-irradiation is because we know that the total dose is probably going to be the same, and so we're not really going to impact acute toxicity. But what we're trying to do is take advantage of the fact that late responding tissues are more sensitive to fractionation, and so they are more going to be subject to the sparing effects of fractionation. So it's really for those late responding tissues and to kind of mitigate that late toxicity that we decrease the dose per fraction. And then because we also know that total treatment time matters, we do BID treatment, so twice daily treatments to kind of decrease that total package time. But I think the key takeaway here is that acute toxicity generally is a function of the total dose, and late toxicity, very generally speaking, is a function of the dose per fraction. There's a problem that I have seen on practice questions for the radiation biology board exams. And they give you a list of different fractionation regimens, and they ask which regimen will have the worst late toxicity. And they'll give you different regimens like 50 grain 5 fractions, 40 grain 15 fractions, 60 grain 30, etc. So they're all different dose per fractions. And what you have to do is use the BED equation to calculate the BED for each of these using the alpha beta for whatever tissue of interest. And they'll tell you what alpha beta to use. Usually it's 3 because you're concerned about normal tissue toxicity. And then you kind of the smallest BED that you're able to calculate using those different dose per fractions is the answer. And so that tells you that for late toxicity, dose per fraction is really what matters. This graph is a very simplified image because, of course, all tumors are going to respond slightly different to radiation, and all of our normal tissues are also slightly different when it comes to how they respond to radiation. But very simply, this is a pictorial way of representing everything that we're trying to do in radiation, which is to maximize the probability of tumor control while minimizing the probability of normal tissue damage. And in our next talk, we're going to talk about something called normal tissue complication probability curves, or these NTCP curves, that try to model the probability of achieving a particular toxicity to a tissue at a given dose of radiation. And just as there are NTCP curves, there are also TCP curves, which are tumor control probability curves, which is the probability of achieving tumor control at a particular radiation dose. As you can see, these curves are sigmoidal. So at low doses, there's a very slight effect. And then there's a particular range where that curve sigmoidally jumps up. And so our probability of tumor control jumps up at a particular dose, and that probability of normal tissue damage also sigmoidally jumps up at a particular dose. And so everything we try to do in radiation is with the goal of keeping our radiation dose within that therapeutic index, which is within that optimal ratio between those two curves where the tumor control probability is high, but the normal tissue complication probability is low. And so, that's sort of that therapeutic index, or that window within which we are trying to deliver our radiation dose. This was a ton of information. So here's a summary slide with some of my key takeaways. The very first thing you should take away is that radiation dose depends on many things. So when you're evaluating any radiation regimen, think about the total dose that is being delivered, and also think about how many treatments are being required to deliver that dose. Or in other words, what is the dose per fraction? It's also really important to consider the alpha-beta ratio of the tissue that you're considering. An alpha-beta ratio is almost like a surrogate for the sensitivity to fractionation of the tissues that are being treated. So our late responding tissues, which remember are most of our normal structures like our lungs, kidneys, livers, as well as some unique cancers such as prostate cancer and breast cancer that are more slow growing. These late responding tissues have a higher alpha-beta ratio, and they're more sensitive to fraction size compared to early responding tissues. And remember, early responding tissues, I like to think of these as the tissues that are going to respond to radiation regardless of the dose. So these are your rapidly dividing cells, including most of your tumors. Think of really rapidly growing tumors such as squamous cell carcinomas of the head and neck. Also think of rapidly dividing tissues in our body like skin cells, the lining of our intestinal tract. These rapidly dividing early responding tissues have a lower alpha-beta ratio, and they are less sensitive to fraction size. Finally, the other thing that really matters when we deliver radiation is the total treatment time. And this factor is one that is probably least well understood, and it's not included in our biological equivalent dose or our equivalent dose at 2 gray per fraction. That's the EQD2 equations. So total treatment time is not accounted for in these equations, but we do know from studies in head and neck cancer and from gynecologic cancer that total treatment time definitely matters. as we just said, we use different calculations to relate these factors. So those equations are listed there, the BED equation and the EQD2 equation. And if you're ever trying to compare effects between different fraction regimens, it's always good to convert each of those regimens to either BED or EQD2, and then use that as a comparison so that you're comparing apples to apples rather than something completely different. And then finally, early responding versus late responding tissues are not to be confused with acute toxicity versus late toxicity. Keep in mind that acute and late toxicity can affect both types of tissues. Acute toxicity is characterized by acute inflammation, which makes sense, and it is a function of the total dose that we're giving. Late toxicity, on the other hand, is characterized by fibrosis and sclerosis, and it is a function of the dose per fraction. And if you want to compare different regimens and which one will have a worse late toxicity, calculate the BED, and whichever regimen has the highest BED, which takes into account dose per fraction, that regimen will have the worst late toxicity. Thank you so much if you are still here with us chugging along through these slides. The goal of this talk was really to kind of place into context how we think about total dose per fraction, and how that plays into toxicity when it comes to our normal tissues. These concepts were ones that I did not understand as a medical student. I actually did not understand them until a few months to maybe even a year into being a resident in radiation oncology. And so I wanted to kind of break things down very simply, and, for folks that are early on in their radiation oncology careers, kind of explain these concepts in a way that makes sense, because I feel like we talk about this in clinic all the time. But if you don't have an understanding of the radiation biology behind it, it's a difficult concept to grasp. So hopefully this was helpful in making things make sense a little bit. And in our next talk, we will be going over some common dose constraints and how we think about those. Thank you so much.